Hello everyone, you're watching PhysioClassroom channel, and in today's video we are going to practically demonstrate some of the exercises based on BRUNNSTROM concept that can be utilized by a physiotherapist to prevent and treat hemiplegic shoulder pain. Some of the important points that are needed to be considered by a physiotherapist while designing these exercises, which are intended to improve the shoulder range of motion and shoulder control, are: number 1, adequate handling. A physiotherapist should know how to handle a hemiplegic upper limb during the performance of range of motion exercises. Number 2, not taking the shoulder beyond 90 degrees of elevation in the acute phase. That is, as the patient starts improving and can contribute in the performance of range of motion exercises, the therapist can then start with the progression of taking the shoulder beyond 90 degrees of elevation. Number 3, maintaining the scapulohumeral rhythm. A physiotherapist must know how to take the scapula into elevation and upward rotation during mobilization of the shoulder beyond 90 degrees. Number 4, avoiding fast and vigorous passive movements of the hemiplegic shoulder joint, as it can result in development of injury to the periarticular structures, as well as can result in uncontrolled increase in the spasticity levels. Number 5, preferring the plane of scaption for improving the range of shoulder abduction and external rotation. And finally, using indirect methods of mobilization to treat hemiplegic shoulder pain when the patient is too apprehensive to move the shoulder joint. So keeping this in mind, let's start with the practical demonstration of few of such exercises that can be done in sitting position to prevent and treat hemiplegic shoulder pain. The therapist makes the patient sit on a low couch or on a stool so that both the feet are resting on the floor. The therapist now supports the patient's involved upper extremity before starting with passive range of motion exercises. One hand of the therapist supports the patient's wrist and hand, while the other hand cups around the patient's elbow. The patient's wrist is maintained in slight extension using the therapist's index and middle fingers, which are placed on the areflexic zone on the palm of the hand. Utilizing this hold, the therapist can now guide the patient through range of motion exercises at shoulder, elbow, and wrist joints. During the early stage of hemiplegia recovery, the patient's attention is drawn to the up and down movements and the pull and push movements, even though the patient might not be able to assist. Forearm supination is incorporated in all the up and pull movements, while the forearm pronation is usually incorporated in all the down and push movements of the shoulder joint. The push and down movements are intended to facilitate the upper limb extensor synergy, and the pull and up movements are intended to facilitate the upper limb flexor synergy. The exercise can be varied by altering the speed of movement, by utilizing the postural reactions such as ATNR during the performance of the exercise, and also by using associated reactions to facilitate movements on the involved side. As the patient starts recovering and can contribute actively, the exercise is now modified to gain shoulder movements beyond 90 degrees. The therapist now changes the hold and now supports the hemiplegic upper limb with only one hand. The other hand is made free to provide scapular mobilization and to facilitate shoulder movements beyond 90 degrees. Using the free hand, the therapist can now passively mobilize the scapula into elevation and upward rotation while taking the hemiplegic shoulder beyond 90 degrees of elevation. This not only helps in maintaining the normal glenohumeral rhythm, but also prevents the unwanted stretching of the periarticular structures that can often lead to the development of hemiplegic shoulder pain. The free hand of the therapist can also be used to percuss and provide cutaneous stimulation over the upper trapezius muscle in order to facilitate the scapular elevation movement. As the patient is able to demonstrate a shoulder elevation movement, the therapist next reduces the assistance provided to the hemiplegic arm and now asks the patient to try and hold the position of the shoulder in space and not let the shoulder fall down. The therapist next aims at developing shoulder control by promoting all three types of muscle contraction in the middle range. The isometric contraction is facilitated by giving command, hold, do not let your shoulder fall down. The eccentric contraction is facilitated by giving command, bring your shoulder down but slowly. And the concentric contraction is facilitated by giving command, now pull up and bring your shoulder up. Exercises are initially performed in small ranges and gradually the range of motion is increased as the patient gains more voluntary control over the shoulder range of motion. In hemiplegic patients who develop severe shoulder pain due to vigorous forced passive movements, a strong tension develops in the pectoralis major muscle and the other muscles surrounding the shoulder joint. As a result, the patient keeps the shoulder immobile and close to the body. Such patients often become very apprehensive and do not allow any movement to take place around the shoulder joint in anticipation of severe pain. In such patients, the treatment exercises should incorporate indirect shoulder mobilization using trunk movements. The patient is instructed to self-support the hemiplegic upper limb using the normal hand. The patient is now instructed and motivated to move the trunk in different directions, which results in considerable amount of shoulder mobilization. Inclining the trunk forward results in gaining the shoulder flexion movement. The greater the trunk inclination, the more the shoulder range is obtained. Similarly, trunk rotation movements can help in the restoration of the shoulder abduction ranges. Rotation of the trunk results in alternate shoulder abduction and adduction movements. So these were some of the exercises based on BRUNNSTROM concept of treatment that can be utilized in the stage 1 and 2 of hemiplegia recovery to ensure pain-free restoration of shoulder range of motion and to develop shoulder control as well as treat hemiplegic shoulder pain. I sincerely hope that the information shared by me is going to be helpful for physiotherapy students and young practitioners. Do keep motivating us with your comments and feedback. See you all in our next video. Till then, keep learning, keep sharing, and stay connected.